Good morning and good afternoon, according to your time zone. Here is the lecture for antiviral drugs and pharmacotherapy. This lecture is intended for postgraduate physicians who are preparing to undergo their master degree examinations in different medical specialties at College of Medicine, Min University, Egypt. Sometimes I will speak in Arabic to explain some points that need to be explained for those physicians. However, I will resume back to English, so if you're not an Arabic speaking, don't be disturbed. Let's begin with an introduction. What are viruses? Viruses are obligate intracellular parasites. Their replication depends primarily on synthetic processes of the host cells. Therefore, to be effective, our antiviral drugs must either block viral entry into or exit from the cell or be active inside the host cell. لما بنيجي بنتكلم كده عن النهارده هنتكلم عن الأدوية اللي بتستخدم في علاج الأمراض الفيروسية، وزي ما انتم شايفين في الصورة فيروسات كتيرة جدا موجودة، بعضها خطير جدا محتاجة يعني specific therapy. فاحنا بنبدأ بنقول ان هذه الفيروسز بتبقى obligate intracellular، يعني هي الريبليكيشن بتاعها بيعتمد على دخولها جوه الخلية بتاعت خلايا الإنسان، وبتبدأ تستغل الماشينري اللي موجودة جواها to replicate. عشان كده لما بنيجي بنحكي ان الانتي فايرال دراجز بتاعتنا هتبقى زي ما هنشوف في السلايدز اللي جايه، هتبقى متخصصه في ان هي يا اما تمنع دخولها الخليه، خروجها من الخليه، او تشتغل على البروسيسز اللي هي بتعملها جوه الخليه. And here is our first lecture adapted from Basic and Clinical Pharmacology, the 15th edition. It is 2021. Useful antiviral compound must discriminate between host and viral functions. With a higher degree of specificity, agents without such selectivity are likely to be toxic for clinical use, and here is our second reference for this lecture. الأدوية بتاعتنا هتبدأ تشتغل على الفيروسات، وبالتالي لو ما كانش ليها سبيسيفيستي معينة هتبدأ برضو بتأثر على بعض الإنزيمات أو بعض البروسيسز اللي موجودة جوه الخلايا الطبيعية بتاعتنا، وبالتالي التوكسيستي بتاعتها هتزيد. هنعرف كمان شوية إن في some serious toxicities that might be encountered with these antiviral drugs. فنخلي بالنا ان مش كل الانتي فايرال دراجز واحد، لا من ناحيه السيفتي ولا من ناحيه السلكتيفيتي، وبالتالي يعني we should be cautious while selecting the proper antiviral drug to treat each viral infection. As we have mentioned, we have drugs that might block entry or exit of the virus, and we have also drugs that will act on the processes that the virus exploit inside the human cells. And here is a diagram. Knowledge of the mechanisms of viral replication has provided insights into critical steps in the viral life cycle that can serve as potential target for antiviral therapy. كل step من دول بدأ في بحث على ان احنا نطلع لها دراج معين ممكن يتفاعل معها، ممكن يعيقها، وبالتالي ينفع كأنتيفيرال دراج. Recent research has focused on identifying agents with greater selectivity, higher potency, in vivo stability, and reduced toxicity. وده الهولي جريل اللي احنا بنتمناه in cancer chemotherapy, in antiviral chemotherapy، ان احنا بنلاقي حاجة تكون selective و less toxic أو as much as we can search for. Antiviral agent can potentially target any of the following replication steps. Let's begin with viral entry, blocked by fusion and entry inhibitor in HIV infection. And we have also tocosanol for herpes simplex virus, bevacizumab for respiratory syncytial virus. These drugs acting on the step of viral fusion and entry. After this, we have also interferon block some viruses enter infusion, block also their penetration. Okay, it is used hepatitis B virus, hepatitis C virus, and other viral infections. After penetration, there is a process of uncoating to release the genome of the virus. After this, another process of nucleic acid synthesis, whether DNA or RNA. And the process of uncoating, we have amantadine and rimantadine for influenza viruses. And for the nucleic acid synthesis, we have non-nucleotide and nucleotide reverse transcriptase inhibitors in HIV, and nucleoside or nucleotide analogs for herpes simplex virus and hepatitis B virus. After the nucleic acid synthesis in retroviruses, there is a process of integration inside the host genome, and we have drugs called integrase strand transfer inhibitor for HIV, like raltegravir. After this, there is also protein synthesis inhibitor blocked by protease inhibitors in HIV and hepatitis C virus. After the protein synthesis, there is a process of packaging and assembly of the viral protein and its genome, whether DNA or RNA, and release. And we have neuraminidase inhibitors for influenza that block their release, like zanamivir and oseltamivir. We have antiviral therapy for herpes simplex virus, cytomegalovirus, varicella zoster, hepatitis C, hepatitis B, influenza, HIV, respiratory syncytial virus, and we will also discuss our current knowledge about SARS-CoV-2 antiviral therapy. And antiviral drugs share the common property of being variostatic. They are active only against replicating viruses and do not affect latent viruses, and there is a huge clinical challenge to be addressed in the near future, especially after a recent report has showed Ebola virus to remain latent for years. فزي ما انتم شايفين احنا عندنا مجموعات من الأدوية هنشوفها وهندرسها باختصار كأنتيفيرال دراجز. في صورة تانية جميلة جدا برضو وفيها تفصيل أكتر للأدوية بتاعتنا. أدي عندنا الفيروسز وهي بتعمل penetration في الأول fusion وentry. عندنا هنا مثلا fusion inhibitor زي الانفيوفيرتايد، ريسبتور انتاجونست زي المارافيرود والحاجات للاتش اي في. عندنا البروسيس بتاعتنا هو عندنا الانكوتنج انهبيتور زي ما احنا لسه متكلمين عليها، امانتادين وريمانتادين. بعد كده قلنا بيتصنع الجينوم بتاع الفيروس، تمام. عندنا الترانسكريبشن انهبيتور زي الزيدوفيودين. عندنا الريبليكيشن انهبيتور سواء ار ان اي بوليميريز انهبيتور سفوزبوفير ان هيباتيتس سي فيروس، او دي ان اي بوليميريز انهبيتور زي الاسايكلوفير زي ما هنعرف برضو دلوقتي حالا. ولقينا في البروسيس بعد كده في الريبليكيشن بتاع الفيروسز عندنا حاجه اسمها نون ستراكشرال بروتينز مهمه للريبليكيشن والماتيوريشن بتاع الفيروس inside the cell. وطلعت بقى أدوية جديدة هنعرفها برضو في الهيباتيتس سي فيروس زي non-structural 5A protein inhibitors زي التجلاتازفير. في ريليز inhibitors زي الوسلتاميفير والزناميفير. في بروتيز inhibitor ريتونافير. برضو دي صورة صورة كويسة. في معلومة برضو نعرفها it is of clinical importance, whereas some infections require monotherapy for a period of time, like herpes simplex virus and influenza. Others require multiple drug therapy for indefinite period, like HIV. In chronic illnesses such as viral hepatitis and HIV infection, potent inhibition of viral replication is crucial in limiting the extent of systemic damage. Importantly also, there are limited guidelines for adjusting dosages of antiviral agent to maximize their antiviral activity and to minimize their toxicity. Consequently, take care of this piece of information. Clinical use of antiviral drugs must be accompanied by particular vigilance for unanticipated adverse effects. علاج كل إنسان بيختلف عن الآخر. دي حاجة اسمها personalized medicine، area جديدة ومهمة، يعني مهم إن انتوا برضه تبقوا عندكم فكرة عنها. ومع بعض الأدوية خصوصا الأنتي فايرال دراجز ومثلا حاجة زي الأنتي إبيليبتيك دراجز، في بعض الأدوية بيبقى مهم إنك أنت كمان تبقى keep vigilant، واعي واخد بالك for unanticipated adverse effects. ما تظنش إن أنت بتكتب نفس الدواء لنفس المرض وهيبقى فيه نفس الأوتكم. لأ، في حالات كتيرة بيبقى فيها unexpected outcomes, unexpected adverse effects, and you should advise your patient to report any change of clinical or medical significance that he or she might encounter. طيب، عندنا في السلايد دي هنشوف إن non-selective inhibitors of virus replication may interfere with host cell function وبالتالي results in toxicity. وبالتالي زي ما بنحكي إن احنا selection of the proper antiviral drug should be tailored and adjusted for each patient personally. To be also noted that the course of viral infection is profoundly affected by interplay between the pathogen and the host defense. So, the presence or absence of pre-existing immunity, the ability to mount and increase humoral and/or cell-mediated immune response, the stimulation of the innate immunity, all of these factors, as well as others, are important determinants of the outcome of viral infection. The state of the host defense need to be considered when antiviral agents are used and we should evaluate it. Okay, so each patient, as we have said, has a peculiar immune system that should be evaluated from a clinical point of view. Perhaps he's on an immunosuppressive drugs, perhaps he is suffering from debilitating diseases, perhaps he is suffering from immune dysregulated disorder or immune deficiency disorder. So when we select the antiviral agent, we should also know the immune and the general health status of our patients. Regarding the mechanism of action, we just want you to know the name of the drug, which virus that is affected by this drug, and the mechanism by which this drug is acting. For instance, we have cytomegalovirus and herpes simplex virus. Cytomegalovirus, we may use gencyclovir or foscarnet in case of resistance, and the mechanism is inhibition of DNA polymerase. For herpes simplex virus, we have many drugs: acyclovir, valacyclovir, famciclovir, bencyclovir, and foscarnet, and acyclovir resistant, as we said before, and we may also use gencyclovir. And all of these drugs inhibition of viral DNA polymerase, but for which virus? Herpes simplex virus. Okay. For varicella zoster, we have acyclovir, famciclovir, valacyclovir, inhibition of DNA polymerase. I think we don't have postgraduate students for ophthalmology, so you just might ignore these drugs for the eye. And of course, if we have some, they should know it, but I don't think we have postgraduate ophthalmology students. For hepatitis B virus, we have lamivudine, entecavir, adifovir, tenofovir, and they inhibit the ionic hepatitis B virus reverse transcriptase. We have for hepatitis C interferons, like interferon alpha, inhibition of viral protein synthesis, entry, several steps, okay? And we have also direct acting hepatitis C virus drugs that will be discussed later, and they are very important nowadays. For the influenza viruses, influenza A and influenza B. Influenza A, amantadine and amantadine, but unfortunately, because of resistance, some guidelines, including the CDC guidelines, are not recommending them anymore. They inhibit the viral uncoating, as we have said before. For influenza B, we have oseltamivir and zanamivir, and they are release inhibitor neuraminidase inhibitors. For HIV, we have enfuvirtide, inhibition of viral fusion. We have receptor antagonist maraviroc, inhibition of viral entry. We have zidovudine, stavudine, lamivudine. They are nucleotide reverse transcriptase inhibitor. We have nevirapine and efavirenz, and other drugs, non-nucleotide reverse transcriptase inhibitors. And we have raltegravir, inhibition of viral integration. We said it before, integrase strand transfer inhibitors. We have sakinavir, indinavir, ritonavir, lopinavir, and others, inhibition of viral protease in HIV. And we have also ritonavir as a pharmacokinetic enhancer by inhibition of other drugs metabolism. So ritonavir, as you might see, might be used as a pharmacokinetic enhancer, as well as it is also an inhibitor of viral protease. Mainly it is used as a pharmacokinetic enhancer. For Lassa fever and respiratory syncytial virus, we have ribavirin, which acts via inhibition of viral RNA synthesis. This man, Dr. Raymond Skenazy, is a leader of, we owe him very much. He is originally an Egyptian citizen, born in Egypt, immigrated to USA in the 60s, and is one of the pioneers in pharmacotherapy or in developing of antiviral drugs, and he's the inventor of sofosbuvir. Okay, sofosbuvir has made a revolution in treatment of HCV, made it a curable disease in few months using oral medication. So we owe this man very much, in fact. زي ما انتم شايفين في السلايد اللي فاتت كنا بنحكي على الانترفيرون كعلاج للهيباتيتس بي والهيباتيتس سي فيروس. Hepatitis C, which is perhaps endemic in Egypt, was a very catastrophic disease with horrible complications, including cirrhosis, liver failure, and of course death for decades. And the treatment was costly, using interferon injections for 48 weeks or something like this. And also not only expensive, but also toxic in many cases with profound adverse effects. Until sofosbuvir has been invented in 2014, and now it is a very easy disease to be managed. Okay, so we have an era of direct-acting antiviral agent for HCV infection, hepatitis C virus infection. Sofosbuvir is a non-structural 5' nucleotide polymerase inhibitor, which is pan-genotypic, genotype 1 to 6 of HCV. We have also other drugs that have been invented, like non-structural 5A inhibitors, And these proteins, non-structural protein, whether 5A, 5B, or else, are of crucial importance in HCV replication. يعني لما دكتور ريموند اكتشف إن في drugs هتشتغل على هذا non-structural protein، فوجئنا إن هذا الدراجز بقت كيوراتيف، بقت بتعالج الهيباتيتس سي فيروس، ما بقناش محتاجين للانترفيرون ل 48 أسبوع أو غيره. فطبعا عملت ثورة بلا نقاش في علاج ال HCV، بقى حاجة يعني very easy and very manageable and less costly بكتير عن الحاجات اللي كانت الانترفيرون هو اللي كان بيتاخد لفترات طويلة. فعندنا مهم انكم تعرفوا الاسماء دي في منتهى الاهميه. عندنا السوفوسبوفير طبعا ده الاساس، عندنا النون ستراكشر 5A انهبيتورز، الليدي بازفير ده جينوتايب 1 4 5 6، داكلاتازفير انبليبتازيفير بانجينوتيبك، وميتاسيفير والباسيفير جينوتايب 1 and 4، فتبقوا عارفينها. وعندنا كمان بروتيز انهبيتور لل HCV بنقول عليها نون ستراكشرال 3 4A 3-4A بروتيز انهبيتورز. عندنا الباريتا بريفير، باريتا بريفير ده بيبقى المفترض معاه لوميتاسيفير وركزوا في دي داسا بيوفير، للأسف مش موجود في مصر الداسا بيوفير، تمام، وبيبقى موجود الريتونافير يعني. وعندنا كمان يعني هو موجود بس من غير الداسا بيوفير، جليكا بريفير، بيبقى معاه واحد تاني اللي هو البرنتاسيفير، وده فور جينوتايب A 1 to 6. وعندنا ده برضو الأخير ده موجود في مصر اللي هو جرازو بريفير بلس الباسيفير، والسيمي بريفير بلس السوفوسبوفير فور جينوتايبس 1 and 4. and I don't recommend semi-prepared. It is an old one. Huge adverse effects encountered in some patients, and I have a published case report including a fatal case that has used the semi-prepared. So we have the more safe drugs. We have sofosbuvir plus lidibasvir or sofosbuvir plus daclatazvir. طبعا of course plus minus ribavirin according to the guidelines that you should focus on, but this is a general lecture for all antiviral drugs, so not specific for HCV. I'm just giving you some outlines that you should know it and you should prepare yourself to be familiar with, because as you know, and of course I think you are all practicing, especially those involved with internal medicine with its different specialties, with many of these antiviral drugs. The last one, non-structural 5B non-nucleotide polymerase inhibitor, dasabuvir, which was originally thought that it will affect only genotype 1, and that's why they have not used here in Egypt. This was a very unfortunate mistake in my point of view, and I have said it at the time, but currently it is well known that it affects both genotypes 1 and 4. So in these others, in the remaining slides, we will have some clinical insights about the use of many antiviral drugs in treatment of many diseases, okay? For instance, let's begin with influenza A and B treatment. We have oseltamivir and zanamivir. Oseltamivir oral, zanamivir inhalation or orally. We have the doses here for adults and for children. For oseltamivir, we have a dose for children aging 1 to 12, and for zanamivir, we have children above or equal to 7 years. So please take care of which route of administration, and also take care about which group of patients. And I personally recommend that you get familiar also with the doses. Now you are postgraduate and you will prescribe these drugs. I think if you are a specialized doctor, you will prescribe it at one time or another. So why not to be familiar with? And we have some valid comment adopted from this wonderful reference. In all the slides, the reference is written. And I have deleted some what can I say, advanced information. I deleted some drugs which are not present in Egypt, but I remained some which are also not present, hoping that it will be present soon. Let's see the comment here. Their effectiveness in prevention or treatment of complication is unclear, although some analysis suggests that oseltamivir may reduce the frequency of respiratory tract complication and hospitalization. Oseltamivir side effects, nausea and vomiting, can be reduced in frequency by drug administration with food. This is a very good pharmacokinetic advice. Zanamivir may exacerbate bronchospasm in patients with asthma, so take care. Amantadine and rimantadine, which are no longer recommended in some guidelines, as we have mentioned earlier, because of current resistance to these drugs. Not recommended for routine use unless antiviral susceptibilities are known. يعني إذا عرفنا إن هم قابلين لسه الفيروس قابل إن هو يتعالج يبقى منتدين بنديه. طبعا الكلام ده بيحصل في البلاد اللي هي اللي عندها الإمكانيات إن إحنا نعرف القصص دي. هنا الأمور مش بالبساطة. فواضح طبعا دلوقتي إن الأوسيلتاميفير والزاناميفير ليهم الأبر هاند على طبعا الأمانتادين والريمانتادين في التريتمنت of influenza viruses. Okay. For prophylaxis, we have oseltamivir and zanamivir, and again, amantadine and rimantadine not recommended in the current guidelines, as mentioned before. Prophylaxis must be continued for the duration of exposure and can be administered simultaneously with inactivated influenza vaccine. Unless the sensitivity of isolates is known, neither amantadine or rimantadine currently recommended for prophylaxis or therapy. Respiratory syncytial virus, we have ribavirin by a small particle aerosolized ribavirin, and here is the dose. Administered 12 hours per day from a reservoir containing 20 milligram per milli for 3 to 6 days. Use of ribavirin to be considered in treatment of infants and young children hospitalized with respiratory syncytial virus pneumonia, bronchiolitis, according to the American Academy of Pediatrics. For cytomegalovirus, we have many drugs, as you can see. We have ganciclovir and valganciclovir. Val is a prodrug drug which is used orally with a better pharmacokinetic profile. Ganciclovir, there is oral and there is parenteral. And in case of resistance, we have foscarnet, which is also not myelosuppressive and active against both acyclovir and ganciclovir resistant herpes viruses. We have also other drugs like cidofovir and fomiviricin. Unfortunately, foscarnet, as far as I know, is not available in Egypt. Hopefully, it will be available. There is some regulatory measures that should be modified and some vital drugs that should be made available. And hopefully, this might happen in the near future. Okay. For instance, here in the comment of valganciclovir, as you can see, has largely supplanted oral valganciclovir has supplanted oral ganciclovir and is frequently used in place of the intravenous one. As we have said, has a very good absorption and pharmacokinetic profile. Here is intravitreal بيتحقن في جوه العين في الفيتروس. Fomiviricin has reduced the rate of progression of cytomegalovirus retinitis in patients whom other measures have failed. or not tolerated. Okay, Gencyclovir and Valganciclovir are approved for treatment of cytomegalovirus retinitis in patients with AIDS. They are also used for colitis, pneumonia, or wasting syndrome associated with cytomegalovirus and prevention of cytomegalovirus disease in transplant recipients. So this information are not only intended for ophthalmologists who focus on the retinitis, but also for internists who might encounter many of these mentioned disorders. مرة تانية احنا بنعرف الدراج، الروute of administration، الكومنت بتاعته. I recommend انكم كنتوا تبقوا familiar with the dose. In varicella, we will see, is it immunocompetent or immunocompromised? In immunocompetent, we might use oral acyclovir and valacyclovir. And here is the dose, which is important at least in some cases. 20 milligram per kg maximum, 800 milligram, 4 or 5 times daily for 5 days. And for valacyclovir for the children 2 age and above, 20 milligram per kg, 3 times per day, not exceeding 1 gram 3 times per day for 5 days. Again, treatment confers modest clinical benefit when administered within 24 hours of rash onset. For immunocompromised patient, we have intravenous acyclovir, the dose 10 milligram per kg every 8 hours for 7 days, and a change to oral valacyclovir can be considered once fever has subsided and if there is no evidence of visceral involvement. For herpes simplex encephalitis, we have intravenous acyclovir. For neonatal herpes simplex, which might be potentially fatal, we also use intravenous acyclovir. So this is what about genital herpes simplex? Genital herpes simplex might be primary or recurrent. I removed the section for recurrent. Let's focus on the primary genital herpes simplex. We may use acyclovir with intravenous, which is the preferred route for severe infections that need hospitalization, or might be orally for 100 milligrams 3 times per day for 7 to 10 days, which is preferred for those patients that who don't need hospitalization plus adequate hydration. But for instance, what if she's pregnant and cannot handle oral drugs or intravenous drugs? We might also use topical acyclovir 5% ointment. To be noted that this topical preparation does not relieve the systemic symptoms or the untreated areas. So when we use it topically, we put it for all areas affected, and we try to manage the systemic manifestation accordingly with safer drugs. Valacyclovir orally might be also used 1 gram 2 times per day for 7 to 10 days, as effective as acyclovir and administered, as you can see, less frequently. We have also famciclovir, which is also similar to the effectiveness to acyclovir For mucocutaneous herpes simplex, which is usually occur in immunocompromised host, we might use acyclovir intravenous or orally, but look at this oral dose, 400 milligram 5 times daily for 10 to 14 days. So we have a higher dose for longer duration. So remember, it is immunocompromised, not immunocompetent patients. We might also use the topical preparation 5% ointment. But remember, oral and intravenous treatments have supplanted topical therapy, except for what? We might use topical for small, easily accessible lesions. This is not the case in most of our patients, especially those in immunocompromised patients. But it is a valid statement. If the lesion is are small, easily accessible, topical therapy might be enough with analgesics. We have also valacyclovir orally and famciclovir, and again you will notice that the dose is higher, the duration is longer because this is an immunocompromised patient. So recurrent herpes simplex orolabialis, and it is recurrent because this is the usual case. Those patients who are suffering from herpes simplex orolabialis also report recurrent lesion more frequently. We have topical penciclovir available in Egypt. We have valacyclovir orally. To begin early is the wisest approach. We have famciclovir, we have docosanol, topical also. So as you can see, we have many alternatives to choose from, and I prefer to begin with the topical penciclovir. What about the management of herpes zoster? Whether immunocompetent or immunocompromised, we have 3 drugs: cyclovir, valacyclovir, and famciclovir. You will encounter here and there, but the difference that we might use a cyclovir intravenous in treatment of herpes zoster in immunocompromised hosts, and this is one difference you should notice. Another difference is that sometimes the duration of therapy is longer. Like if you see famciclovir in the orally, an immunocompromised host, that is oral use in immunocompetent host, 500 milligram 3 times per day for 7 days, but in immunocompromised host it is used the same but for 10 days. Valacyclovir may be more effective than acyclovir for pain relief. Otherwise, it has similar effect on the cutaneous lesion. The duration of post-herpetic neuralgia when we use famciclovir is shorter than with placebo, and this is also very good to be noticed, and because post-herpetic neuralgia is a very disturbing disorder our patients suffering from herpes zoster suffer from. What about the treatment of chronic hepatitis B? Actually, this is a huge remaining challenge in our medical practice. We have a lot of patients suffering from this disease, and still we don't have the revolution that has been made for hepatitis C virus. Hopefully another Dr. Raymond Ashkenazi, hopefully also an Egyptian one, might lead this anticipated revolution. We began therapy with interferon alpha 2B. It was taken 3 times per week, injections, subcutaneous, okay, for 16 to 24 weeks. The improvement has been encountered in about 1/3 of cases, and this was not properly tolerated by the patients. So an improvement has been done, and we had beguilated interferon alpha 2A. It was once weekly injection for 48 weeks, and the improvement was the same, about more than 1/3 by a little, but it was also not properly tolerated with some patients who don't want to take these injections, which also have some serious adverse effects have been encountered in some, and also were costly. السعر والأعراض الجانبية كانت بتخلي عيانين كتير ما بياخدوهوش، خصوصا ان النتيجة يعني التلت اللي بيتحسنوا يعني، وممكن تلتين بتبقى الأمور يعني border line أو ما فيش تحسن. Then we had some oral drugs like lamivudine and adifovir, entecavir, and tenofovir. Lamivudine orally 100 milligram per day for 1 year to 1.5 years, and also used as part for HIV infection. This is the dose for lamivudine. Monotherapy well tolerated, effective in reduction of hepatitis B virus DNA, normalization of alanine transaminase levels. However, resistance developed in about 1/4 of recipients. دي كانت المشكلة. في تحسن صحيح، لكن ربع العيانين حصل لهم resistance وما حصلش التحسن الكافي، فبالتالي ما بقاش هو البيست تشويس. طبعا مع اللاميبيودين كان في برضه الاديفوفير، بعض الناس بيفضلوه اديفوفير 10 ملغ per day for 48 weeks، وده عمل return of ALT levels اللي كانت عالية in more than half patients to 3/4 of patients, improved liver histopathology in more than also half of patients, and it was reserved for lamivudine resistant cases. To be noted that renal function including proteinuria should be monitored. Then Antiviral, which is also active against lamivudine resistant hepatitis B virus, and tenofovir. For tenofovir, which is 300 mg per day for 48 weeks, the alanine transaminase level returned to normal in about 3/4 of patients. Liver histopathology improved likewise. Resistance is uncommon, and this is a very good advantage. We are waiting for the studies that tested tenofovir alafenamide, because it showed initial better safety profile than the one available, which is tenofovir disoproxil. So we have lamivudine, which is the standard one, and we have 3 drugs in lamivudine resistant HBV: adifovir, entecavir, and tenofovir disoproxil, and we are waiting for tenofovir alafenamide. For hepatitis, then we will move to treatment of chronic hepatitis C. Again, we began with ordinary interferon alpha 2A or alpha 2B. It was taken by subcutaneous injection 3 times weekly for 1 year. After this, we had beguilated interferon, which has increased the pharmacokinetics, decreased the clearance of interferon, and helped it to make it once per week injection, but for 48 weeks. After this, we had a protocol that combined beguilated interferon, either alpha 2A or alpha 2B, with ribavirin, but the dose has been variable. In alpha 2B, 800 to 1,400 milligram, alpha 2A, 800 to 1,200 milligram daily of ribavirin. And we looked at what is called SVR, Sustainable Virological Response, for which duration after therapy we will see no recurrence of HCV in the tests made for those patients. About sustainable virological response were seen in about half of the patients infected with HCV genotype 1 and about 3/4 of the patients infected with genotype 2 and 3. And these are the genotypes which are prevalent outside Egypt. We have more prevalent genotype 4. But as you can see, it was long duration, costly, adverse effects have been encountered. And also the SVR has not been reached in about 1/4 to 1/2 of patients. So it was far away from being considered ideal treatment for hepatitis C virus. But fortunately, we had the direct acting HCV drugs, and these are the combination which are available and safe to be used from my point of view at least. We have sofosbuvir, lidivasvir, sofosbuvir, daglatasvir, sofosbuvir, veliptasvir, elbasvir, grazoprevir, ritaprevir, ritonavir, omitasvir, plus dasabuvir, which is not available in Egypt. This dasabuvir, we have ritaprevir, ritonavir, omitasvir without dasabuvir, unfortunately. And here are the genotypes affected by this combination, which are all used orally. The guidelines are present. Sometimes we added ribavirin for selected patients, and the duration of regimen varied from 8 to 24 weeks. It is being updated regularly. And here is a website for one of these guidelines. For COVID-19, we have what is called the repurposed antiviral drugs. Repurposed, it was not originally antiviral drug, but it has been found that they have antiviral activity, so have been repurposed with promising results at some times. We have nitazoxanide, repurposed antidiarrheal, original antidiarrheal, azithromycin, repurposed macrolide antibiotic, and the combination, which Egypt has been the one or the country that has first hypothesized and published in a very reputable journal, which is Pharmacological Research. We have also ivermectin, repurposed antiparasiticide. To be noted that remdesivir, oseltamivir, lopinavir, ritonavir, and favipiravir are being shown to be either without efficacy or potentially have serious adverse effects. And here is another paper regarding the potential toxicity of remdesivir and favipiravir and the unwise use of dexamethasone in cases of COVID-19. I encourage you, if you have time, to see it for your clinical practice with COVID-19. To be noted also that we have tocilizumab, a human anti-interleukin 6 receptor antibody, and intravenous immunoglobulin have shown efficacy for selected severe to critical COVID-19 patients.